All right. Hello, everyone. Welcome to today's webinar on engaging healthcare organizations for HIV prevention and care. This is the third and final webinar in this series addressing priorities in HIV testing. We are recording today and we'll share the recording via the NASTAD and RAISE websites. But you can also access previous webinars in this webinar series, as well as our monthly webinars on both of those websites. So just a little bit about RAISE and NASTAD. RAISE is the Research Alliance and Implementation Science to End HIV Hub, which is a part of the University of Washington's Fred Hutch Center for AIDS Research. NASTAD is the National Alliance of State and Territorial AIDS Directors. We are a national nonprofit organization that provides technical assistance and support to state and local health departments around the country and the U.S. territories. You can learn more about our work as well as the RAISE Hub's work on our websites, and we'll put the links in the chat. We also encourage you to reach out to us if you'd like to speak with the RAISE team about how implementation science can support your HIV prevention and care efforts. And just upcoming webinar that we'll be hosting, we're skipping the month of May, but we will be hosting another webinar on June the 5th, and we'll be sharing more details in the next few weeks about that. So today we're going to be hearing from Public Health Seattle-King County's EHE Healthcare Collaborative. So our panelists are Dr. Matthew Golden, who's a professor in the Department of Medicine at the University of Washington and is also the director of the HIV/STI HCV control program at Public Health Seattle-King County. We also have Dr. Colin Fields, who's the medical director for government relations and public policy and the medical program director for the HIV and PrEP program at Kaiser Permanente, Washington. And our final panelist is Dr. Kevin Wang, who's the medical director for Swedish LGBTQIA+, the LGBTQIA+ program at Swedish Health Services. So I'm going to stop sharing now, and we're just going to have a brief introduction about the Healthcare Collaborative, and then we will get into our discussion. We have some questions that we're going to be starting with, but feel free to use the Q&A in the chat function to ask your questions at any time. So I'm going to pass it off to Dr. Golden to kick us off.
Are you guys able to see my slides?
Yes, but you're not in, oh, there you go. Now you're in presenter mode.
Okay, great. Well, thank you everybody for being here. And I'm going to be talking about HIV, promoting HIV testing in public health through engagement with the healthcare system. I'll start by just giving a little background on this topic on the rationale for doing this, and then we'll talk about our experience doing this sort of work in King County. So some of you who have been on some of these previous seminars might recognize this slide. In public health, I think we sort of adopt a multi-pronged approach to testing. There are instances in which we provide tests and other services. There are instances where we fund testing, and then there are instances where we're promoting it. So in prior seminars, we talked about providing HIV testing in sexual health clinics and in emergency rooms. And those are meant to focus often on higher risk populations and populations that are harder to reach. Today, we're going to be talking about promoting HIV testing and prevention interventions in the broader healthcare system. And here we're really talking about a mix of higher and lower risk populations. And in my experience, this is often the neglected part of what we do in public health. Now, some of that I think reflects the history of HIV/STI. So when you think back to the 1980s and 90s, and I'm probably one of the few people who was involved in this in the 90s. Most affected communities were really marginalized and often hidden. And I think that's still sometimes true, but it's not true to the same extent as it was very early in the HIV epidemic. At that time, our treatment was very poor. There was no such thing as PrEP. And public health relied very heavily on behavioral interventions the Debbies and the Ebbies, for some of you may remember those things. There was a big focus on community engagement and CBOs, who were the ones often providing those behavioral interventions. And some of this reflected the demands of the communities that were affected, which was very reasonable at that time. But if we fast forward to where we are now, HIV prevention is now primarily biomedical. When you think about EHE, our pillars are really testing, treatment, and PrEP. And most HIV testing and PrEP and almost all HIV care is done through healthcare organizations, although some CBOs have become healthcare providers. I think that public health, however, has not consistently expanded community engagement to include large healthcare organizations. Now, when we think about HIV testing, the federal government in 2021 funded a little over 1.7 million tests. And we identified a lot of cases, but despite that, only 22% of all new HIV diagnoses were a result of federally funded testing. The rest were tested through other mechanisms, sometimes local government or state government, but mostly not. And if you look at this overall across different states, there's a lot of variability how many of the cases are identified through federally funded testing, but almost never does it exceed 30%, and often it's substantially lower than that. So I think that public health clinics and CBOs play an essential role in testing, prevention, and care, but most HIV testing, PrEP, and HIV care occurs in large healthcare organizations. And they are central to our success in achieving EHA objectives. Of course, our need to engage with large healthcare organizations is way bigger than HIV alone. It affects our success related to HCV, which is probably our most neglected high priority infectious disease. Syphilis, which is an expanding crisis. It was important in the global Mpox epidemic. It affects TB, and it interdigitates with the opioid crisis, which is affecting so many of our areas. So public health CBOs and the wider healthcare system each play an important and complementary role. Each is critical. And it was with that idea in mind that when we were developing our EHE plan here in King County, we put together this healthcare organization collaborative. Now, these were our initial objectives. The overarching objective was to improve LGBTQ healthcare and expand clinical infrastructure as it relates to HIV/STI. And this was responsive not only to EHE, but also to local statewide recommendations, which I won't go into in great detail, but just there was already some momentum in this direction. Our specific objectives were to increase the data collection related to sexual orientation, gender identity, and sexual history, so SOGI data, which is really important in focusing HIV/STI related efforts and PrEP efforts and monitoring the success of those efforts. To increase testing, HIV testing, including one-time testing for all adults, as well as more frequent testing in populations at higher risk for HIV infection, and to increase PrEP use. And we simultaneously had a separate collaborative that was focused on emergency rooms, which I'm not going to discuss in greater length right now. Now, over time, I think those objectives evolved. We started out with one idea, but things change. And some of that reflected the interests of the group. Some of it, I think, probably reflects changes in our perspective, and some of it just reflected circumstances which were beyond our control. So we had obviously no idea that there was going to be an Mpox epidemic, but this group allowed us to disseminate information about that and build testing infrastructure and the infrastructure to provide TPOXX treatment. It's been critical in our developing new syphilis testing guidelines for our jurisdiction in the state and then in implementing them. We've used the group to vet our doxy-PEP guidelines, and we're now working with it to promote HCV treatment by distributing lists of people who we believe are untreated to the different healthcare organizations. In terms of developing this, for those of you who are interested or considering something along those lines, we really focus primarily on large healthcare organizations and community health centers. And the goal was to include a physician or advanced practice clinician from each group. Now, it's hard to know who to include, and I would say that probably identifying these people was largely dependent on my professional network initially. I would say that some HCOs have also included non-clinical staff. In terms of from the public health perspective, our staffing included a lead physician, which for our group was me. And I think that will present some challenges for some jurisdictions where they have minimal access to physicians, particularly physicians who actually see patients who have HIV infection. However, I do think there's an opportunity to partner with academic or Ryan White clinical partners to have that sort of medical leadership within such a collaborative. We also had an EHE staff member, Sarah Magnuson, who helped organize the meetings and data collection and has been central to integrating the work with other EHE activities. Now, in terms of how this developed, I think a few thoughts I have about this is that it's important to realize that participation for some of the organizations is going to vary over time. Some HCOs are not very interested until they are. Some decrease their involvement over time, but then in other instances, then later become more interested again. And I think for the leadership in these things, a key issue is making sure that you're sort of serially outreaching to your collaborators, respecting the fact they have a lot of demands on their time. And so sometimes they won't be available and other times they are. I would say that some things that I think can help promote momentum within these sorts of groups were that we had some grants available, which I'll talk about more in a minute, to help seed new initiatives within these organizations. And which I think in some instances has encouraged the organizations to develop their own internal momentum. I think that the HRSA EHE grants to the community health centers were important for some of the organizations that have participated. But probably the most important thing is really the passion of the people who you get to be involved in these things. That if you can recruit the right people from the different organizations, it's their passion which will drive things. So I had mentioned that we did have some grants to healthcare organizations. These were 1- and 2-year EHE funded grants from Public Health Seattle King County. They varied from $22,000 to $88,000 per year. They went to some of the community health centers as well as Kaiser Permanente, and they were mostly really about hiring new staff, EHR changes, improving SOGI data collection, things along those lines. In terms of the content of what we've been doing, it's important to realize this is a technical cooperation model. It's not a TA model. So it's not really that public health has a lot of answers to give to everybody else. I think it's more that there's a bi-directional or multi-directional flow of information that everybody is bringing expertise to the group overall. We have 30-minute one-on-one meetings between public health and each of representatives from each of the healthcare organizations approximately every 6 weeks to discuss progress on work within the HCO or the healthcare organizations, which this is varied from group to group. And the goal is to build and sustain momentum, identify and troubleshoot problems, and try to identify successes which members of the group can share with others in the group. Remember, it's not something where public health is giving people information. The group is sharing information with one another. We then have these monthly meetings, which include everybody. Typically, we've had brief presentations on public health topics, some of which are given by members of the group, and then updates from the group, or discussion points from the group overall. We have been trying to collect data, which includes a variety of process outcomes, as well as information like the number of adult patients seen in primary care, SOGI, HIV testing, HCV testing. So this slide is just showing you some of the process outcome data. They're collected. We have data from 9 of the 14 HCOs provided data on this. You can see in some instances, people have accomplished a process outcome data, and others it's in process. Sometimes it hasn't really gone in. So most of the organizations have engaged key stakeholders within their own organization. More variable in terms of training providers in LGBT care. So 44% of the organizations have done that, 33% are in the process. Most of the organizations have instituted or are in the process of instituting efforts to improve SOGI data collection. We're more mixed on getting sexual histories. 78% of the organizations have instituted plans to improve HIV testing. 67% have trained providers related to PrEP. So overall, the sites that participate in this have almost 1 million adult patients, or saw almost 1 million adult patients between January 2021 and December 2023. So that's a little over 50% of all adults probably touch one of these organizations over the course of this time period. I think this is likely an undercount, though, because not everyone gave us information. Overall, these organizations had identified about 6,800 MSM had been seen in these organizations. The proportion of men they identified as MSM varied, but mostly it was between 2 and 6%, which is within the plausible range. So I think the SOGI data collection is roughly right. The group had provided, though, different organizations had provided almost 5,000 people with PrEP in 2023, with 10 to 40% of MSM being on PrEP in the different organizations. So if you look at the figure, what you'll see is overall, looking at across the entire organization, SOGI data collection was complete on 44% of all patients across the different organizations, but it varied a lot. HIV testing had been done in 33% and HCV testing in 29%. Again, there's a lot of variability here, though, in these different organizations. I would say it's often difficult to get data from the organizations. I think our medical collaborators, who are amazing, often do not have that much access to these data. And Kevin and Colin can probably comment on this, that it's a process to accomplish that. But I think that over time, most have been successful in doing this. And it's really a testament to their commitment. I also would say that Sarah Magnuson, who's been coordinating this, has been really key. She's a person who is able to be persistent with a smile, which is really a good way to be, and I think a good way to accomplish it. So our hope is that over time, we'll be able to track trends in these outcomes. So in conclusion, I think large healthcare organizations are key collaborators in the HE. It is possible for public health to engage these organizations in the HE-related work. I think key ingredients include medical leadership in the health department, good coordination by EHE staff, and engaged leaders, at least some of the HCOs, who can act as peer leaders within the group. We've had some successes, I believe. I think we've had good engagement. I think we have pretty good population level coverage with about half of all adults seen in an organization which participates. I think we've seen good progress building LGBTQ-related infrastructure within the HCOs. And in some instances, the participants in these organizations, in our HCO collaborative, have gone on to play larger public health roles within their organization, which I think has really helped us even more. I think that we've improved communication between our health department and the different healthcare organizations and among the HCOs between one another. Now, I can't really say, though, how much any of those things is really a result of this collaborative. Maybe they would have happened anyhow. I couldn't say that. This is not a randomized control trial. My final point would just be that building something like this is a long-term project, but it's part of your public health infrastructure. And it's useful way beyond just HIV STI. So that is my last slide and comment. This just gives you the names of different people from different organizations who have been participants in this effort, and we're very grateful to all of them. So I will turn it back over to you, Krupa, to lead us in some discussion.
Great, thank you so much. Before we get into the questions, I do want to ask Dr. Wang and Dr. Fields to kind of talk a little bit about your organizations, who are your patients that you serve, what are the services you provide, and then if you could talk about what have been the benefits for your organization in participating in this learning collaborative.
Go ahead, Kevin.
Okay, you just said both, right? I wasn't sure if we should go first. Well, hello, everybody. Good afternoon. I think most people are in the afternoon phase, although if you have people from Alaska, good morning for those in Alaska and in Hawaii. I'm Kevin Wang. I use he, him pronouns. I work at Swedish Health Services or Swedish Medical Center, We are a secular component of a larger Providence St. Joseph healthcare system, which spans 7 states and is a faith-based healthcare institution. But I get to work in the secular component of our healthcare system. As previously mentioned, I get to serve as the medical director for our LGBTQIA+ program, and I also get to work in graduate medical education as well. So I get to serve as clinical faculty with one of the family medicine residency programs and one of the and their OBGYN program at Swedish as well. Swedish as a healthcare system in general provides primary and specialty care. So we have predominantly in our primary care space, we have OB, GYN, pediatricians, internal medicine, and family medicine. We have people who are physicians and advanced practice clinicians, so our nurse practitioners and physician assistants. But we also have a number of specialty services as well, including orthopedics, dermatology, infectious disease, and the usual gamut of specialty services. But in the area I get to work on when it comes to our LGBTQI+ program, we have services which range from clinical to non-clinical, from healthcare navigation, particularly for our trans and gender diverse patients, to the provision of certain aspects of gender-affirming hormone therapy and surgical services, to primary care services for our LGBTQ and I patients as well, including all the other communities who are in the +2. You want me to end there first and give some space for Colin so I don't spend 15 minutes talking?
Hi, everyone. I'm Colin Fields. I use he and him pronouns. I work at Kaiser Permanente, Washington. Washington is one of the smaller regions within Kaiser Permanente. Our medical group has about a little over 1,000 physicians of different disciplines. It's a multidisciplinary group, HMO. We have about 600,000 patients in Washington State. I'm a family physician and currently I'm the medical director of the HIV and PrEP program. And previously I was the director of the gender health program and worked a lot with Kevin in that role. And then I'm currently the medical director for government relations and public policy, which is how I started to interface, I think, more with Matt. So I'll turn it over to the initial question here. Maybe I'll answer the initial question about the benefits of this collaborative. I think that healthcare is really very collegial generally, and I found that this collaborative has been nothing but collegial. People want to lean into improve care for their communities, and whether that be within their own organizations or other organizations. So I think it's been really useful to just connect with other systems in terms of networking, troubleshooting problems, and then meeting outside of the collaborative itself. So I've met with some of our community health programs, FQHC programs, about some of the programs that we've implemented at Kaiser Permanente. And then additionally, it has been really useful to have some funding that was provided by EHE. So we utilized the funding to develop a community resource specialist position. And that position has been really useful for doing using our STI report to do proactive outreach to people who were diagnosed recently with gonorrhea and syphilis, to make sure that they knew about PrEP as an option for them, and then get them referred to PrEP expediently. So it was a much more proactive way of reaching out for patients who presumably do have risk based on their STI screening. And then our community resource specialist also has been working kind of on regional documents for different parts of Washington State that we had translated into Spanish and Amharic, so that when patients came into our system, which is a complicated system, they had an introduction to how the system functioned, and were able to better engage in care. And then our community resource specialists also spend a lot of time connecting with different case management programs across the state. so that we had better ways of facilitating signing up for early intervention programs or accessing resources for new diagnosis of HIV or for people who are looking to start PrEP. So those were some of the initial thoughts on my end, and I'll turn over to Kevin for his.
Thank you, Colin. I just want people to point out, just since Colin mentioned we worked together, Colin was also the person who helped me learn how to provide test-to-pill pellets for patients on hormone therapy. So I will be forever grateful for Dr. Fields. Being part of this collaboration, I think, spans multiple, stages, I suppose, mainly, from our individualized healthcare systems to the broader healthcare organizations in itself, and then how things can then, how we can have an even further reach within our region and our state. So starting with just our individual healthcare system at Swedish. So as Colin mentioned, we were able to access some funding, and being part of our LGBT+ program, we were able to secure some funding, which was really quite vital to our opportunity to study what is the best way for us to increase SOGI data capture. So as Dr. Golden mentioned, SOGI being sexual orientation, gender identity, what's the best way? And knowing we have multiple generations of healthcare clinicians who have varying degrees of comfort with using newer technology, including iPads or tablets, having patients use their patient portal to enter in this information, or the traditional let's just ask and have people fill out paper forms, really gave us the opportunity to study the full gamut of options. And really what we ended up finding out was there wasn't one best way to do it. It really is clinic and clinician dependent, but it allowed our system educator to be able to say, here are the data we have available, and let's see what we can do to help individualize SOGI data capture for each particular clinic and even within teams within those clinics. But again, within the system, being part of this larger collaborative gives us a little bit more sort of oomph when we start talking about particular initiatives we want to start at our healthcare systems. So having something which is a much larger force within our communities really helped us bring attention to what can we do better to provide training and alerts within our electronic health record system to train our clinicians in the provision of PrEP or PEP or DoxyPEP, or offering screening or doing better for screening options and reviewing risk factors for our patients who may be at higher risk for acquiring HIV and other STIs. So having this EHE just helps arm us a little bit better to have those conversations where our leaders in our healthcare systems feel overtaxed, where our clinicians feel overtaxed, and to see the larger community benefit in the work we want to do. Going back to what Dr. Golden mentioned in the previous slides is this collaboration, right? And as Dr. Fields mentioned, we all really want to work together, but unfortunately, the way in our healthcare system works, we are often siloed in our, not just, even in our own system in family medicine and graduate medical education. What can we do to break down the silos within our own institutions? And how can we break those silos down, which are often put in place between larger healthcare systems? So fortunately, Dr. Fields and I have had the opportunity to partner on a few projects and to be able to break those barriers down between large healthcare systems and federally qualified healthcare clinics. What can we do to break down the barriers between larger healthcare institutions where, to be honest, we haven't had the best relationships and have caused harm for our community-based organizations? How can we strengthen those relationships? And being able to partner and have this big collaborative really brings everybody on the same page to really get a pulse of what our communities are asking us and frankly demanding we need to do better. And so it's great to be able to hear all these things, to learn from each other, but really just to show commitment to our communities. Yes, we are in our own healthcare system silos, but we really are here to try to patchwork all the holes which can be present in each of our systems, learn from each other to really provide the safety net for the patients who need us most.
Thank you both so much. So we talked about, the things that have worked in this collaborative. Dr. Golden shared what I think it kind of is most likely like from the health department's perspective. and what hasn't worked in the collaborative. So curious to hear from the two of you, from your perspective as the healthcare organization, what things do you think still need to be improved as far as the collaborative?
Let's see. I mean, I can give some downsides are things that have been tricky in areas for improvement, maybe with some initial thoughts. Um, I mean, I think that the data collection is really tough, especially when it's not in, it's not in a research setting, it's real time. And it's very much a chicken and the egg problem. Like, what we need is more information on the LGBTQ patients. They are very hidden in the chart generally. It's important for us to know about their identities, whether or not they are identify LGBTQ, but even more so, we want to know about their behaviors. And it's hard to capture both of those things really well in electronic medical records. And I think, you know, it would be beneficial for public health for us to advocate for the big systems like Epic to really improve these processes for that data collection. I think that one of the trickiest parts that I had is the questions that we developed for data collection to provide to Matt and Sarah. They got too specific to the point where, I was getting like an N of 1 or 2 in terms of the number of people who met all the variables that were required for the question. And over time, that still hasn't really improved that much in our system. And I think will take quite a while for it to improve. Kevin, your thoughts? I have more for later, but over to you.
What's interesting, particularly when it comes to the data component, is what has helped in terms of having this collaborative has forced my system to give me, I guess, an ad hoc analytics team, but much of the same barriers Dr. Fields faced when it comes to collecting those data. So, we have had the same difficulties when it comes to the more granular components of the questions EAG is asking us to collect. And I think it just shows the problems we have with our larger electronic health record systems is even though we're all getting information or we're all using the same vendor, there's so much variability amongst all the different electronic health record systems. It just makes it too complicated or more complicated than I would like. Other parts which have been, I wouldn't say haven't worked, but just has made things difficult is the pressures on larger healthcare organizations where I don't know about Kaiser and some of the other healthcare systems where people are joining from, but the frequent restructuring, reorganizing, despite all of the great work we want to do through the collaborative, it's really hard to get things done in a system which frequently changes. So we went through a bunch of restructuring with our health equity office, certainly with our brand merger with Providence and Swedish. And so when we have these larger public health emergencies, for example, with Mpox or with the increasing rates of syphilis, particularly congenital syphilis, trying to get things done in a manner which addresses the acute need has been, for me, one of the biggest barriers. We have all this great information and recommendations from Dr. Golden and King County Public Health and the CDC, but to get all those things changed or updated in a relatively quick manner for me has been something which really just hasn't worked. We have the information, but I can't do anything with it because I can't get anybody to update those things. Well, and being part of a faith-based institution, I'm just gonna leave that out there.
I think that in the imperfection of data, we've had to use some imperfect proxies. So like when it came to Mpox, we really were only able to outreach to people who are taking PrEP and people who are living with HIV. And not all of them were necessarily at risk for Mpox, but it definitely didn't capture the entire population that was needed to be outreached to, and we still haven't been able to do that. And I think one of the things that's been really glaringly apparent within the collaborative is just smaller organizations are really able to implement changes quicker. And, we really are kind of at a glacial pace sometimes for making certain changes. That's been really quite apparent when we share data within the organization or the collaborative.
Glacial,
Wow.
maybe being optimistic.
And I would say though, guys, as somebody sort of not in your organizations, I think you have made a lot of progress, and you have been able to get access to the data. I know it's hard, it's imperfect, but over the course of this, you have made progress on it. So you're being I'm more positive about it. Of course, I'm not doing the work, but I think you've done a lot.
Do we have any questions from our participants? You can feel free to unmute, or you can use the Q&A function or the chat. Okay, while you all are thinking, I'll go to my next question here. Do you all have any tips or recommendations for health departments that are interested in building new relationships with healthcare organizations? A lot of times, folks that work at health departments, especially if they're not, somebody who is a MD, they might kind of struggle to get their foot in the door at a organization, healthcare organization in their community.
Why don't you go first, Kevin?
I would say what thank you, Dr. Fields. I will say what Dr. Golden mentioned in your presentation was it really starts with that network. And I think it's building the relationships and being persistent. And what I would say is, if you're running into a situation where someone either isn't responding, is trying to find someone else who can. I can't imagine the number of emails Dr. Golden and Sarah have had to send out to different healthcare institutions. But for example, I can tell you when I initially brought this up to our infectious disease and preventive health and population health team, they just didn't have the bandwidth. And fortunately, when Dr. Golden reached out, it was something our program could initially start and sort of build a foundation in which we can provide the data Dr. Golden and the team is looking for, and to maybe start the participation and such. So for me, building those new relationships is try to find the allies and those who are passionate for the work and to keep trying. Dr. Golden, I don't know if you reached out to other people before reaching out to me, but I know some of our infectious disease specialists, and it can be difficult to hear back. So yeah, I don't know. I think that would be my biggest tip, would be to find those who you can end up building those relationships with, and it can take a while.
I was going to say that I think that it just keep meeting and making sure that each meeting has some shared objective and that it's understood kind of what the objective of each meeting is going to be. If organizations are able to dedicate time or resources, that's great, but I know that time and resources aren't always prolific. And then, the more that meetings can be like well planned and effectively organized with the objectives, keeps people on tasks, and I think keeps an understanding of what why they are there. And then I think it's useful to clarify roles and what expectations are, both like in the immediate but also moving forward. I think probably the people on this webinar will laugh at this, but I don't have a lot of experience with grant funding. So, you know, is really helpful. I think it would be really helpful to have a better understanding of when grant funding is allocated, how to be proactive at like the information that I need to be collecting proactively, the things that need to be objective, the things that can be subjective, so that you can be doing that along the way to satisfy the requirements of the funding. Because when you're trying to recreate that retrospectively, it's a lot more challenging than doing it prospectively. And then the more that tips that can be given for improving the data collection in the real world, the better, because it, you know, I think I've learned a lot from it so far, but it's really tricky. And I did not have I've definitely had experience with doing clinical studies that are so much more controlled, but looking at just massive amounts of data and trying to figure out what is actually useful and whether or not it's actually correct is really challenging. And so if you have educational resources about that, that's great.
Okay, we have a participant question. You've spoken about the important benefits of this collaborative for the patient and health outcomes. What have been the benefits to the healthcare organization?
Well, you know, I think maybe one anecdote I could share is that at Kaiser Permanente, we had developed a more proactive STD report, which we get weekly, looking at new cases of gonorrhea and syphilis within the system. And like I talked about earlier, proactively outreaching to those patients. So I met with a number of the other FQHCs to develop a similar report for their FQHC so that they could start implementing the same types of outreach. So I think that that maybe that was not as much of a benefit to us, but I think that it's a benefit to our community to be sharing those types of innovations. And then, yeah, I think that's where I'll go over to talk, Dr. Wang.
I would say at least from what I've been able to observe from our conversations is I feel communities have, I won't necessarily say the best, but maybe an improved perception of what healthcare systems mean in a community. And what I mean by this is, you know, the outreach to community-based organizations, the emphasis on serving communities which have traditionally been harmed by the healthcare system. I feel the relationship we have with communities as a whole has, well, I'll just say has gotten better, or at least has changed. And being able to implement, you know, some of the strategies laid out by other healthcare systems, FQHCs, what we learned from the collaborative, really allows us to provide individualized healthcare services to our patients who may be at risk for acquiring HIV and other STIs, and provide care which is, again, more individualized, which makes want people to be more engaged with the healthcare system, which allows us to really focus on other metrics which, fortunately or unfortunately, we're being judged by insurance companies, by Medicare, by CMS, and really provide whole person care for the management of their chronic health conditions and such. So I feel the public perception is changing of our healthcare institutions, especially when they hear about these types of collaborations, and knowing it's being informed by our communities, so then we can provide the services they're looking for.
I think that just aspirationally, you know, one of the things that's been useful with this collaborative is just identifying the problems that we're all experiencing And I think that we have identified a number of problems that we actually find to be needing some addressing at a larger venue like healthcare policy and a legislative approach. So hopefully we're able, I mean, we've been meeting with Matt and with GR teams to look at, like, are there some actual bigger fixes that need to be implemented that maybe we can advocate for. So I don't think that that would have been nearly as apparent if we hadn't been meeting as a group over the last couple of years and kind of running into these problems over and over again that have really become apparent that they need a larger fix that we can't do.
I will add one more benefit is I feel the meetings, whether it's the one-on-ones with Sarah and Dr. Golden or us as a collaborative, can kind of be a therapy session. And I'm not trying to make it too lighthearted or anything, but there's something which can be therapeutic to hear other systems are kind of running into the same issues, and maybe hearing, another system which kind of did a workaround, but it's kind of, I don't know, it's kind of nice for us to kind of be together and commiserate together instead of feeling as if you're isolated and alone in your healthcare system. So, back to the benefit, I think it could be therapeutic. And again, it just feels as if we're breaking the traditional silos and wanting to have higher market shares in your community. This is really bringing us together as a group to serve our community as a group. So I find it to be really inspiring and gives me, hopefully everyone else, but at least gives me a little bit more optimism in how healthcare is glacially changing to serve our communities.
If I could comment on this policy issue, I would also say from the health department's perspective that, at the program level, for those of us who work in HIV STI programs, while have some ability to influence sort of legislative policy and try to push our things forward, if we can go to the leadership and say, Kaiser wants this, and Swedish wants this. It's not just Public Health Seattle King County. We have, a network of collaborators. We're all on the same page, and their government affairs people are pushing this forward. It's not just coming from county government. It's much stronger. Our position is way better if it's truly a collaborative kind of effort. So I think this is one of those objectives. We did not have this as an objective when we set this up. I had not thought about this. I don't think any of us had. But as you develop the relationships, additional opportunities present themselves.
Other questions from our participants?
Are other people doing this who are in the group out there in other jurisdictions? I haven't heard a lot about it, but I'd be interested if people have experiences to share. I think I'd be interested.
We have a few minutes left. I have one more question if there are no participant questions, and then we'll give you all each an opportunity to share any final thoughts. So this question is more kind of following along the lines of the healthcare organization perspective. So for folks who work in healthcare organizations, what advice or recommendations would you have for how they can best work with their leadership to promote LGBTQ care or improve HIV-related care?
You want to start this one, Dr. Fields?
No, I was going to say you should. You worked on this a lot.
So I kind of feel bad for saying this. I think some of this is also public knowledge, so I'm just going to be transparent and open. So at least the way we approached it, and fortunately it was a way which worked for our system, and I can't say this is something which is going to work for every healthcare system. You know, what ended up helping us was one, you know, our you know, Swedish has the webpage which has our mission, vision, and values. And what I ended up doing was we ended up writing a letter to our leadership to show how we were not living up by our mission, vision, values, not just serving our LGBTQ communities, but also, again, communities which have traditionally been harmed by the healthcare system. And while this was happening, and while we were also integrating in our residency program an LGBT plus training curriculum, it just so happened at the same time, there was a lawsuit which was filed against Providence Healthcare System. So for us, it was sort of this, and we didn't know this was even happening at the time we were presenting this to Swedish leadership. And as these stars sort of aligned, it kind of gave us the opportunity to bring together people in different areas, which have also had a particular passion for this work as well. And so putting aside the legal ramifications of what happened with the lawsuit, it was very much sort of the conveyor belt analogy. I don't know if people are familiar with Dr. Kamara Jones, is finding the allies you have in your spaces, and then using your collective voices to then start tapping on the shoulders of other people. So while everyone is going down the conveyor belt in one direction, you have those of us who have kind of turned in the opposite direction, walking against the conveyor belt and tapping the shoulders of those individuals to then start moving people in the direction you're wanting your system to go into. So for me, what worked best was finding the allies in your spaces in order to get the attention of leadership. The other one was, you know, because our residency program had the opportunity to partner with other community-based organizations, that allowed us to build those trust and those bridges and the trusting relationships to get it kind of transferred to the larger system as a whole, and really to identify what our community is demanding healthcare institutions to do, and then to transfer that to the request to leadership. And two other things, which I don't know if it's necessarily good or bad, I'll just say it was a strategy which worked for us, was comparing ourselves to other healthcare institutions. Kaiser, which was previously known as Group Health, was far and away the pioneer in the provision of gender health services, while Swedish, compared with some of the other healthcare systems, we hadn't done anything. Despite the work we were trying to do at our residency program. And so using competition as a way to tell leadership, do you want to be last? And the answer was emphatically no. So kind of appealing to their sense of competition was also something which was a strategy we use. I'm not going to kind of load the strategy with describing it as good or bad, but it just is. And then the last thing is, unfortunately, when you want to start these types of programs, there is a financial, or there's a cost to it. There's a fiscal note, and being able to pitch it in a way which can either be financially neutral, or in the in the eyes of leadership, what can we do to make it not just a sustainable program, but a thrivable program as well. So that was sort of the strategy we took. But the part which really I felt got the ball rolling is finding out who you can tap to help lead those conversations and to get all the yeses from everybody else before you have the big pitch meeting. Because if you can get all those yeses in hand before, it can make things a lot easier.
I was going to take a very different lens on this question, because Kevin, I think you answered it so well. You know, when it comes to PrEP, I think that when systems are getting involved in developing PrEP programs, initially it's very manual. But as you start getting more and more numbers, I think it's really important to automate the process as much as possible. So we have developed a lot of automation around our PrEP lab ordering, so that it's just done by the computer, and it's not as manual for the clinician, because usually PrEP programs are run by 1 or 2 people, but they might be managing thousands of patients. And the less, order entry that they have to do, the better, the more that their work is focused on engagement and follow-up and monitoring and outreach to people who are at risk. That's what people should be doing, and computers should be doing all of the entry if possible.
I would just reiterate Gavin's point about there is some healthy competition out there. And, I think that actually worked with our leadership at the University of Washington when I was pushing this. And I won't name the other organization, but one of our large organizations, which has been slowest, not because the people we engaged weren't good, because they're excellent. But for whatever reason, it was hard for them to move their organization. The thing that really worked was them eventually becoming frustrated and saying, we are the laggards. We are bringing up the rear. Nobody likes to bring up the rear. So I think that has been really helpful.
All right, thank you all so much for this great conversation. We are at time, so we're going to wrap up. Thank you to all of our panelists today, and thank you all for joining. As I said earlier, we will share the recording, and we hope to see you in June. So thank you so much. Have a good rest of your day.